Okay, very good. So this is the topic given to me today, and I know we are approaching the end of the day, so you must be pretty tired. So let's go through this in the next 20 minutes or so. The topic is rapid diagnostic tests in ID. What do we mean by that? What we mean is something that gives us the diagnosis quicker rather than through conventional diagnostics, such as a culture report. These are my disclosures. And we'll start with a case. This is a 38-year-old male from Chennai with a single kidney, which was incidentally detected, came with fever after having undergone ERCP and stenting for a CBD stricture. He developed high-grade fever and abdominal pain after that. And what you can see here that the liver enzymes, the OTPT, are elevated here. Other than that, nothing much except that there is some evidence of perhaps pancreatitis. On examination, he was icteric and dehydrated. He was on inotropes. Chest was clear. Abdomen was soft with right hypochondrial tenderness. A CT abdomen showed a CBD stent in situ with multiple hypodense lesions, both lobes of liver, possibly cholangitic abscesses with dilated IHBRs and a dilated pancreatic duct. So the diagnosis was septic shock secondary to biliary sepsis. He got started on meropenem. Now, the next day, the blood cultures flagged gram-negative bacilli, and expecting this to be perhaps an ESBL producer, meropenem was continued. Yes, it was an ESBL producer. He was de-escalated to ertapenem. He got clinically better, and the fever was settling. However, 2 days later, he started spiking again. Although hemodynamics were stable, his white count was high. Blood cultures were repeated. Again, gram-negatives were growing. And it was thought that perhaps there was a source in the abdomen, like an abscess or something that wasn't reduced. And fair enough, that was true. There was something in the pancreas. There were lymph nodes as well. And the thinking now was that this was a CA pancreas with obstruction and secondary biliary abscesses. The next day, the blood cultures grew Klebsiella, and this time it was CR Klebsiella on receipt of subsequent sensitivities, and the patient underwent source reduction. So a test the day the blood culture flag was ordered. This was the expert Carba-R test, which you can see here was positive for an OXA48 type carbapenems. Now, what happened next? Remember, this patient has a single kidney, and you would like to avoid polymyxins. If at all you can help that. He was started on ceftazidime avibactam. The stent was removed. Only then did the fever come out, and the stent actually grew CR Klebsiella. And this patient finished 14 days of ceftazidime avibactam. So you can see here how a molecular test gave you the result much before a conventional test and enabled you to avoid a potentially nephrotoxic antibiotic. A second case, 50-year-old male, CKD. This is immediately post-transplant. He had earlier had a CRE, a carbapenem-resistant E. coli graft pyelonephritis 20 days after the transplant surgery, and now presented with fever. So we know he's had CRE in the past. Clinical exam was unremarkable, and as we would expect in the immediate post-transplant period, this turned out to be urosepsis with bacteremia. So what would you do here? Would you give this patient colistin at the risk of graft renal damage?
Yeah.
So what we did was that we ordered the same test, expert Carba-R on this patient, which again showed an OXA48 enzyme. And when the conventional DSTs came back, you can see that this was resistant to everything except colistin. Subsequent sensitivity testing for ceftazidime avibactam showed sensitivity. And so this patient was started on ceftazidime avibactam on the day the blood culture flagged, not waited 24 or 48 hours later for the final report. And he improved, and we were able to preserve renal function. So when you order a blood culture, it sounds quite simple, but there's actually quite a lot that goes on behind the scenes. This is the technique of blood culture collection. You will draw blood here. You will put it into a blood culture bottle, adequate volumes, minimum 20 ml per set. This is put into a machine. As bacteria grow, the technician takes them out, does a gram stain, tells you whether it's GPC, GNB, or even a yeast, and then inoculates it into another machine to give you ID and DST. All this obviously takes time. But you can speed up this process in many ways. You can directly try to identify organisms from sepsis. This is not as yet validated clinically or not available in India as yet. Or you can do other tests on a positive blood culture, which will give you the diagnosis in terms of which organism early and in terms of antimicrobial susceptibility testing, as we'll see. So this is the protocol in my hospital. We draw 2 sets of blood cultures. Volumes are essential. We flag, when it is flagged, the lab calls us. The technician takes the bottle out, does a gram stain on it. We ask them to do a rapid MALDI TOF. This is a combination of, this is magnetic, so this is time of flight. This is MALDI TOF, which is a rapid identification technique. Now, this has to be done on a positive blood culture for it to be clinically useful. So by evening, the lab will tell you what the organism is. PCID is another test, which we will discuss. And if it turns out to be E. coli or Klebsiella, an additional test you can do is the expert CARBA-R test, which I spoke about, which helps you decide, 1, whether there is carbapenem resistance, 2, what the mechanism is. And the literature clearly says that if you do this kind of molecular diagnosis, you are about 36% less likely to die. But it's important that you feedback on it. That is, you have to ask for this early, as soon as the blood culture flags, and you have to act on it by the end of the day. If you do this on 20 patients, you will save 1 life, and therefore should be considered part of the standard of care in patients with bloodstream infections who are typically critically ill. So these are some of the things we do in my hospital. We do MALDI TOF directly from the blood culture bottle. It's better technically for gram negatives than for gram positives. And it's important to do it directly from the bottle. This is important because if you wait for it to grow on a culture plate the next day, it's probably too late in terms of rapid diagnostics. It then becomes conventional diagnosis. The film array test, which we'll discuss about, it includes multiple bacteria, yeast, and resistance markers as well. And the expert CARBA-R is, again, we have that available in our hospital. Other techniques are available abroad, not yet widely used in India. So this is the blood culture ID panel. You can see here, if blood grows GNB and you order this test, you get the report within a couple of hours. It picks up a wide number of hospital-acquired as well as community-acquired bacteria. And obviously, gram-positives are there as well. Yeast can also be identified, but most important, it picks up these resistance genes. I will know immediately whether I'm treating an NDM, different treatment, OXA48-like, different treatment, whether it's even a CTXM that's useful or a community-acquired E. coli or Klebsiella bacteremia, or whether it is something that something not here, something that if it doesn't flag, then either it's sensitive or there are different mechanisms of resistance. We have some experience in the expert CARBA-R assay. This was a poster we presented at ID Week a couple of years ago. And basically what we found was that we looked at 160 odd bacteremias. The most common ones were Klebsiella and E. coli. We used CARBA-R, was positive, showed carbapenem resistance at 58 out of 164. And we showed these genes, OXA48 and NDM genes in many of these patients. We were actually able to escalate the cover if the CARBA-R was positive and to de-escalate it if CARBA-R was negative. And you can also look at the distribution of these enzymes. If it's Klebsiella, it was largely OXA. If it was E. coli, it was largely NDM. And obviously, there were mixed carbapenem producers as well. Note that Pseudomonas and Acinetobacter would produce these enzymes, but they have multiple other mechanisms of resistance. So if you have a Pseudomonas that doesn't show these resistance genes, doesn't mean it's sensitive. It could have a porin channel or an efflux pump that renders it resistant. So this is kind of the protocol we use for CARBA-Rs. Once the blood culture flags, we ask the lab to give us a direct MALDI ID. If it turns out to be a non-fermenter, then you have to use the CARBA-R with a pinch of salt. If there is a carbapenemase gene, fine, you know it's resistant. But if it's not there, it could still be resistant. That's very important. For Enterobacteriaceae, which are largely resistant through carbapenemase production, if there was resistance, we escalate to CR cover, if not already done so. If the CARBA-R test was negative, we can consider de-escalation in a careful situation. You know it's E. coli, you know it's Klebsiella, and after taking other clinical parameters into account. So this serves as a very rapid diagnostic test. It's very useful, readily available. It's a nested PCR. So contamination is not a big issue. Most labs should have this particular test available. So it really helps in early antibiotics, early de-escalation as well, and to try to avoid nephrotoxic drugs like colistin. Now, this was an article which we wrote in IJMM a couple of years back. And what this looked at was the mechanisms of resistance. Because with E. coli, we know that NDM is the big problem. With Klebsiella, we know that OXA48-like is the big problem. With Pseudomonas and Acinetobacter, they have multiple other methods of resistance. Aceneto also produces an OXA23-like enzyme, which again is important. I'll show you why. So this is a kind of summary on carbapenems. If you use these tests, either a blood culture ID or if you use expert carba-R, you have to know the epidemiology in your country. NDM1 in E. coli, OXA and Klebsiella often both are produced. KPC, which is very common in the West, is hardly ever seen in India. And this is kind of a summary of what we see in India from different papers all over India. The second part of the equation is, you may tell me that what does it matter what enzyme is produced? I'm going to give colistin or polymyxin B to all these patients, which obviously is not affected by beta lactamases. They all get better. Now, it turns out that that is not the correct approach in this day and age. These are all studies which looked at colistin on one side versus other agents on the other, largely newer drugs. Meropenem, Vebobactam, Ceftazidime, Avibactam, which we have in our country, other newer antibiotics. And it turns out that most of these studies showed increased mortality with colistin. We know that colistin is not a very effective drug. The highest level you can get around 2 or so is just about close to the break point of the organism. And it's a pretty nephrotoxic drug as well. We all know that. So the current literature as well as guidelines are moving away from colistin if there is an effective alternative. And clinical studies like this support exactly what I'm saying. Ceftazidime avibactam is available in our country. This was a US study which dealt largely with KPC, so perhaps less applicable to our setting. But you can see here that patients treated with ceftazidime avibactam did better than colistin. So colistin is rapidly becoming a bad word. Now, in India, we have this peculiar problem of NDM1 production. So a valuable drug against NDM1 is Aztreonam, which is intrinsically resistant. So can you give the Aztreonam along with ceftazidime avibactam? It's a kind of a triple combo to take care of 2 modes of resistance. ESBLs, the avibactam takes care, the NDM1, the Aztreonam takes care. And so this has been studied. This was an in vitro study from Vellore, which looked at this as a proof of concept. And this was the clinical study we were all waiting for. Again, not a large study, but it clearly showed that the 30-day mortality in the combination group, this widespread common, we give both these drugs together over 3 hours, was about half that in the other effective antibiotic group. So again, favoring the use of this combination therapy over a drug like, for instance, colistin. So this is the current approach to multi-drug resistant Klebsiella. Always decide whether it's true infection or colonization. Do molecular tests soon as your blood culture flags. The cornerstone of therapy is ceftazidime avibactam plus Aztreonam, and you've got to infuse these 2 in combination over 3 hours. If it's OXA48, then the Cas-Avi alone does the job. If it's NDM1, you have to continue the Aztreonam to inhibit that. And obviously, you'll have to ask for conventional DST and for the synergy testing if it is resistant. This will take a day or 2 to come back. Now, if the current IDSA guidelines recommend monotherapy if beta-lactams are sensitive, or if it's ceftazidime avibactam, yes, just use that alone. On the other hand, if all your beta-lactams are resistant, you're usually stuck with polymyxins and try to use combination therapy if something else is sensitive. E. coli is a slightly different ballgame because we know that the mechanism of resistance here is largely NDM1 production. And we have a second valuable drug against E. coli, which is phosphomycin. IV phosphomycin is very much available in India. So this is the same approach. We do molecular testing, OXA48, which is quite rare with E. coli, ceftazidime avibactam alone. Usually it's an NDM1 producer. You continue the Aztreonam as well. You need to give monotherapy if it's sensitive to beta-lactams, if your combination is working, and combination therapy only if non-beta-lactams are used. These are, I'm quoting from the latest IDSA estimate guidelines, which were updated earlier this year. Now, moving on to infections at other sites. Now, in the age of COVID-19, you don't need reminding that the only way to make a viral diagnosis is a molecular test, a PCR test. And this is the respiratory viral panel, which is commonly used across India. You can see that apart from COVID, many other conventional viruses are picked up, and some causes of atypical pneumonia are also picked up. Now, we studied the older version of this particular panel prior to the COVID pandemic, and what we found was that a vast variety of of viruses are out there. If you look for them, you will find them everything from RSV to human metapneumovirus to H3N2 as well as H1N1 influenza. We all know that there's a lot of H1N1 circulating in most parts of the country, including Andhra right now. And it's also useful to know that these are often specific to some times of the year. For instance, in Chennai, we get our rains in winter, the northeast monsoon. At that time, we get a lot of influenza, both H1N1 and H3N2. It's also useful in terms of what you do to the patient. It's not of academic interest. You can treat these patients with oseltamivir if you find influenza. And more important, you can de-escalate. You can get rid of the broad spectrum antibiotics, make it narrow spectrum, or completely get rid of the antibiotic altogether. In our study, the patients who had their antibiotics discontinued after a viral pneumonia actually did better. There were fewer deaths in this patient. So very important proof of concept. If your diagnosis is a virus, please don't give an antibiotic. This is rapid diagnosis from the GI tract. The last time I ordered a stool culture was probably 20 years ago, because simply the paradigms have changed. Most diarrhea, most gastroenteritis is treated clinically. You rehydrate the patient or you give something empirically. Or if you truly feel you need to establish an etiology, you go for this GI panel. So the cases that fall in between that require stool culture really is probably of historical interest. So you can see the number of these GI pathogens that are picked up on a panel. We looked at this as well a couple of years back, and we found that it was quite sensitive and certainly much more rapid. This is a same-day test compared to conventional diagnostics. And you can see that it's very important to realize that there are certain organisms that are missed by the GI panel. So you have to know what is missed. For instance, in our case series, several of these C. diffs were missed by the GI panel. We had to do a C. diff specific two-stage EIA. Aeromonas, CMV, Microsporidia, Isospora, obviously GI tuberculosis would all be missed on, and a couple of cholera and typhoid patients were missed as well on a stool rapid panel. But the advantage is the rapidity of the test and the fact that you need to do it only in a small fraction of patients who are having bloody diarrhea, immunocompromised hosts, severe diarrhea, diarrhea that's potentially communicable, etc. So most patients, just empiric rehydration, a small fraction, straight away do the GI panel. I don't see where stool cultures come in between. This is the meningitis encephalitis panel. Note that a large number of bacteria as well as viruses are picked up, as well as one fungus, which is Cryptococcus. The biggest Achilles heel of this panel is it doesn't pick up tropical viruses. It is geared towards non-tropical or viruses seen worldwide. So you don't have chikungunya, you don't have dengue fever, you don't have West Nile fever here. So that's a problem. So provided you realize that, it still gives you very useful information. Sometimes you can have false positives and false negatives, especially with Cryptococcus. This is notorious for having false negatives. HHV6 can also be overdiagnosed, and it does not include tropical pathogens. There was a nice review on this, which concluded that sometimes you can get false positives with pneumococcus and group B strep. You can also have false negatives where you miss the diagnosis sometimes with HSV 1 and 2. And again, Cryptococcus. For Cryptococcus, please use conventional diagnostics, not an ME panel. Use your India Inc., use a cryptococcal antigen. And the take-home message is that it should not replace regular diagnostics. It's a little bit different from stool cultures. ME panel, the GI panel has almost replaced stool cultures, but not the ME panel. You need conventional diagnostics, and if you're thinking of Cryptococcus, do some other test. It's also important to note that some of these chronic herpes viruses, HHV6, CMV, HSV, can yield false positives. Herpes viruses tend to reactivate non-specifically if you have some other cause of meningitis or encephalitis. So be careful. You don't get CMV meningoencephalitis unless the host is severely immunocompromised. So all of this has to be looked at, the host, whether it fits in clinically or not. We did look at this as well and try to make up an algorithm as to how to approach community-acquired meningitis encephalitis in India. So you start therapy typically for pneumococcus, typically for scrub, and acyclovir for HSV2. And based upon your CSF formula, if it turns out to be bacterial, sometimes you don't identify the bacterium because of prior antibiotic therapy. That is where your ME panel may be helpful, because it picks up dead bacteria through their nucleic acid, not just live bacteria through gram stain and culture. On the other hand, aseptic meningoencephalitis, which is lymphocyte prominent, it's a very predominant, it's a very valuable test. Remember, if it is negative, look for tropical viruses. That's the first thing you should do. Dengue, chikungunya, scrub, any other tropical virus, West Nile, whatever it is, JEV, etc. And if it's very early stage, again, you may have to repeat these PCRs to rule out HSV encephalitis. So this is my last slide. Molecular testing is very important for the diagnosis of hospital-acquired bacteremia and for appropriate antibiotic selection, both correct selection as well as de-escalation. Respiratory viruses are impossible to diagnose without rapid diagnostic tests. We know that in the COVID era. GI pathogen diagnosis is largely molecular. In my practice, I have stopped doing stool cultures. I just treat the patient empirically, or I do these tests. Meningoencephalitis pathogen diagnosis, again, is largely molecular. But remember, the currently available panels don't include tropical pathogens. Thank you very much. That's my last slide. I will stop sharing here, and I'm available for any questions if needed.
Good evening, Dr. Ram Gopalakrishnan. Thank you for the excellent lecture. I mean, I met you a couple of years ago in Chennai, so I'm Dr. Kadian. But I really wanted, I mean, there was some scheduling issues, so we had to push this topic to the end. We wanted all the pages to understand the need of molecular methods. Now we have to listen. We have, I mean, Ram Gopalakrishnan sir can say, NDM movement of the body and KPC. These 5 words or 5 letters should be there in our minds in future. I think you only accept that that's the future of microbiology. Understanding these genes is very important. This is the first comment which I wanted to make. And more interestingly, what I heard from Cepheid is that they're also coming up, adding up the tropical infections to the PCR panels. I'm not sure when will it come, and if it comes, it would be wonderful. They're going to add it to the gene expert module itself. If that happens, I think we have malaria, typhoid, dengue, all at a go. I mean, as an active in this panel. Those are the 2 comments I want to make. But I have 2 questions for you. First question is, you said in your presentation, the oxamorphate was predominant in one of those papers you presented at the IDB. That was a little astonishing because majority of the times we see more of E. coli and then NDM being the predominant one. So without having the molecular methods, would you like to suggest using ceftazidime-avibactam? From the lecture, it looks like using ceftazidime-avibactam with testosterone is going to be of very useful phenomenon. But would that be always the definitive choice? And the second question is, I will finish the questions as like you can answer both. The second question is, how would you compare CARBAR versus BCID2? I mean, in resistance detection or early detection of infection.
Right. So I'll just take the second question first. CARBAR is much cheaper. It costs about 5,000 rupees. BCID would be at least about 15,000 rupees. So the simple answer is, if you know the organism or if you can predict it clinically to be E. coli Klebsiella, Enterobacteriaceae, then just do a CARBAR. You don't need BCID. And where could you predict that clinically? In certain clinical scenarios, for instance, febrile neutropenia, where it's largely their own organisms. Secondly, in the liver transplant unit or CLD patients, they rarely get non-fermenters in the blood. It's usually their own E. coli or Klebsiella. So, or in a pyelonephritis syndrome, if you know it's urosepsis, it's going to be E. coli Klebsiella. So just go for CARBAR. On the other hand, if it's an unknown bacteremia in the ICU, it could well be Pseudomonas acinito. You really need to know the organism and know that if you don't pick up a resistance gene, it could still be resistant. That is the important point. So that's regarding the first question. The other question is regarding ceftazidime-avibactam therapy in India. So I would, there are actually recent ICMR guidelines on treatment of multi-drug resistant gram-negative bacilli. You're welcome to refer to them. And the current thinking is, if your patient is wealthy enough to afford ceftazidime avibactam, it's quite an expensive drug, then they should be wealthy enough to afford molecular testing, because this drug is quite useless if you're dealing with NDM1. And we know that the vast majority of E. coli produce NDM1. So you'll have to combine it with aztreonam. And the problem is, even when you combine the two, it may still not work. And the reason for that is now E. coli has become very smart. I didn't have time to present all that. It's developed resistance to altered PBPs. In other words, there is a small mutation in its penicillin binding protein, which renders aztreonam ineffective. Nothing works except colistin and perhaps fosfomycin. I didn't have time to do that. You have to go to an entire gram-negative talk to take you through that. So you really need molecular tests. You need conventional diagnostic tests to look at sensitivity, synergy, etc. You need both if you're using these expensive drugs. So I would submit to you that there's really no role for using Cas-Avi alone. It just won't work with many of your CR E. coli. I hope that answered your question.
Thank you, Dr. Ajike. It was a wonderful lecture, and we really kind of updated ourselves a lot on that. And we thank you so much. We wish we had you here in person, but probably because of some reasons we couldn't arrange that. We now move on to the next speaker, Mr. Subramaniam Swaminathan, who is again associated with Global Health people, and he is from Chennai. I also request Dr. Madaras to come and co-moderate the session. As we go forwards, this is about getting the right antibiotics, the right dosing, the timing, and all. What I have learned today is that medicine has always been clinical, but we need to upgrade ourselves, and we need to stick to clinical practice while trying to implement the modern technology as much and wherever feasible.
Yes. Sir, can you please unmute?
Yeah. Good afternoon. Yes. First, let me start sharing my slides. First, apologies for not being there in person because of personal emergency at my end. I was really looking forward to being there in person. Unfortunately, like I said, personal emergency. So getting antibiotics right. So why do we need to do this? How do we do this? And what is the most sensible way of doing this? So many studies have told us this, that getting the antibiotic right is absolutely critical. What do we mean by that? If a person is sick and comes to the emergency, you need to get the antibiotic right within 1 hour of the patient coming in of possible septic shock. And it has to be appropriate, meaning it should be an agent which has activity against the pathogen which you are considering. The route of administration should be okay. For example, you can't use intramuscular because absorption from there is unpredictable. Oral is obviously not the right idea. It has to be intravenous, obviously. The dosing and the frequency with the loading dose, that is also important. A lot of people forget to give the loading dose. And if you don't give loading dose, then the steady state takes longer. You take longer to get the right level in the blood. And therefore, the benefit is delayed. Classical example is with colistin, where it took a lot of people a long time to get the loading dose right. We need to keep in mind penetration. For example, if you have E. coli, Klebsiella, amikacin is a lovely drug if you're treating pyelonephritis. On the other hand, the same E. coli and Klebsiella in the lung, penetration is no good. So therefore, amikacin is no good. And sidality is something people talk a lot about. Again, the static versus sidal is probably overstated, but it does carry value in probably certain hosts, maybe meningitis and febrile neutropenia. Outside of this, probably static and sidal is overstated, but even there are questions. So definitely in febrile neutropenia, you want to have a sidal drug, but in most other conditions, static and sidal is more of a boogeyman rather than a real problem. And this is from a very old paper, Anand Kumar and his group. And, they looked at delay in starting appropriate antibiotics and survival. As you can see, they cut it into half an hour time periods and then going forward a little longer. And for every delay in starting antibiotics, there is a fall in survival, a significant fall in survival. So you want to get the correct antibiotic, not just any antibiotic. You want to get the correct antibiotic, and ideally within half an hour of noticing that the person is hypotense, meaning going into septic shock. And any delay there is a problem. And this is an issue even in major hospitals, because while you may write the antibiotic and suggest that it be done immediately, very often when you audit it, you will realize there's a huge gap between your putting in the order for the antibiotic and the patient actually receiving it. And this is due to innumerable number of reasons, often related to the way the hospital functions. So I would suggest the next time you write a stat order, just have a look and see how quickly the stat order is being implemented when it comes to antibiotics. There's significant delays in all of this, and this leads to needless morbidity and mortality and cost as well. So again, how important is it to get an appropriate antibiotic? So that was timing, and this is appropriateness. If you look at getting appropriate antibiotics, the chance of surviving is much, much better if the antibiotic is appropriate at the time of starting the antibiotic. This is true in all groups of patients, whether it's immunosuppressed, COPD, dialysis. You look at all kinds of people, there is a significant benefit, and the benefit only increases as the vulnerability increases. So a young person can probably be able to tolerate being started on an inappropriate antibiotic for a longer period of time. But when you have a 65-year-old dialysis patient with heart disease, that person, if there is a delay in starting the right antibiotic, then their outcomes are pretty much very bad. So it's very important to note that we need to start the right antibiotic at the right time, at the right dose. So this is very, very critical. And these are areas which unfortunately even today are lacking. And one option is to have a hospital-wide system in terms of dosing the antibiotic as the first dose, meaning making sure that the first dose is a standing order for a full dose and not have to worry about writing renal adjusted, this adjusted, that adjusted. Just give the full dose. You can worry about how much dose for the second dose, not for the first dose. So let's look at some cases. This is a real life patient that I faced a couple of years ago. 25-year-old lady who presents with 2 weeks after marriage. A week after marriage, in June, she presented with burning micturition to her primary physician. And she was diagnosed to have honeymoon cystitis, and she was started on ciprofloxacin. She now comes to the ER on ciprofloxacin with high-grade fever, rigors, chills, and flank pain. And at that time, she was actually starting to get hypertension. She was tachycardic. Her blood pressure was starting to fall. And with fluid challenge, she was picking up. And she already had a urine culture, which her primary had ordered. And the urine culture looked like this. So it was E. coli, which was resistant to a couple of antibiotics, but susceptible to a lot of things. The question is, what can we do? So for the longest time, we were dealing with third-gen cephalosporins like ceftriaxone. It's very easy to use. It's very convenient, once daily dosing. It is fairly inexpensive. It is fairly well tolerated. A lot of big advantages. But today ceftriaxone is losing its sheen for a lot of conditions, including salmonella, for various reasons. So the question is, should we be giving this patient ceftriaxone, or should we be going for one of the other drugs? Why not piperacillin tazobactam? Why not aminoglycosides? Why not carbapenem? So the question is, what should we give? So obviously, Cipro is not the right choice here because it is resistant. And today, community resistance to quinolones is up to 70%. So really, giving empiric quinolones, except maybe MDR-TB, is not a good idea. So here's the problem. We now talk about ESBL, extended spectrum beta lactamase. That is enzyme production by the gram-negatives, which inactivates a lot of beta lactams, penicillins, and cephalosporins. And the problem is that in India, very few labs do any kind of testing to identify or label an ESBL. It's also a problem because there are no standardized guidelines for this. So that's a problem. You need to have your own in-house guidelines and kind of adapt that. So the rule of thumb is, if you're resistant to one third-gen cephalosporin, you assume you're an ESBL producer and therefore avoid that. In this, if you look at it, it says cefoxitin resistant. That actually means worse. It usually suggests an AMC, not just an ESBL. And therefore, you would want to avoid all simple beta lactams. And in this situation, for the longest time, we believe that either a beta-lactam inhibitor like cefepime, sulbactam, or piperacillin tazobactam is good enough, and you really don't need to give carbapenems to everybody. And over time, the guidelines have also changed in that we have reduced the MIC breakpoints for ceftriaxone. So much so that more and more we are seeing resistance rather than susceptibility, which is actually in keeping with the real world experience that it doesn't work in many of our patients. A lot of people were enamored with cefepime because there are some purported benefits with certain groups of resistance mechanisms. But unfortunately, when dealing with ESBL, it's not a very good agent. First thing is the MICs there are not accurate. Therefore, the lab reporting on susceptibility is not at all accurate. Number two, even if they say it's susceptible and it's an ESBL producer, cefepime tends to fail very badly, and therefore it is not a good choice in treatment of ESBL-based infection, gram-negative infections. So basically, we need to understand that ceftriaxone and cefepime are not good choices, and you have to read the MIC, the antibiogram and the susceptibility testing very, very carefully. So what should be done? As of right now, if you look at the IDSA guideline for urinary tract infection, where you have an ESBL producer, either from an enterobacteria, say either E. coli, Klebsiella, Proteus, or something like that. If the patient is sick, the recommendation is for a carbapenem. Quinolones are considered acceptable, but quinolones are not probably the best choices in India simply because of the resistance levels. Cotrimoxazole, amazingly, is still a brilliant drug. But then again, using cotrimoxazole IV in a sick patient is probably a little tricky. So most people would probably use carbapenems upfront, and then you would downsize to something else. As you can notice, there is no BLBLI over here, no piperacillin tazobactam or cefepime sulbactam. And that's probably thanks to the Merino trial, where they had patients who had ceftriaxone-resistant E. coli and Klebsiella, and meropenem-based therapy had better survival rates. That is, the meropenem group had 4%, 4 point something percent mortality, whereas the piperacillin tazobactam group had about 12% mortality, so almost 3 times. So obviously, that was a bit of a shock because that was not the outcome they were hoping for. And that study clearly showed that there was a survival benefit for carbapenems upfront. And I would think for your sick patient, the answer would be a carbapenem. And then once the patient is stable and the susceptibilities come back, you probably de-escalate to something else like a BLBLI or even cotrimoxazole. Fosfomycin and nitrofurantoin should be mentioned here as non-options. They are very bad in blood levels, and here you're not treating with a urinary tract infection. You're treating a systemic infection where the patient is going into septic shock, and you probably have bacteria in the blood. So you need to have very, very good blood levels to treat the patient. Aminoglycosides are not bad options at all. You can use aminoglycosides in setting, although most people are uncomfortable using aminoglycosides because of their purported renal toxicity, but that's actually not very true. It's actually a life-saving drug. So the quick answer here would be use the carbapenem and then de-escalate. So this is where the Merino trial came in. They looked at piperacillin tazobactam against meropenem, and meropenem had significantly less mortality as compared to piperacillin tazobactam. But what do? Let's say you have started a carbapenem and the patient is starting to improve. Why not downsize them to something simple? The susceptibilities come back, it's an E. coli, which is an ESBL producer, but it's susceptible to quinolones or cotrimoxazole. What would you do? So you can downsize to oral medications. A, if there is susceptibility that's shown. 2, the patient is feeling better and the numbers are better. 3, there is no obstruction or abscess and things like that. And 4, the person can tolerate orally and GI absorption doesn't seem to be a challenge. So the patient is better clinically. You can definitely change even to oral medications like cotrimoxazole or a quinolone if the susceptibility is there in selected patients. And this would be most of your patients. So that shouldn't be an issue. So continuing with carbapenems is another sin that happens very, very often and is unnecessary both from a cost point of view and also in terms of side effects and drug resistance development point of view. It's important to minimize the days of antibiotic use and also minimize exposure to high-end antibiotics like carbapenems. And switching them down to simpler agents is probably the best thing you can do for the patient's safety. Drugs like amoxicillin, clavulanate, doxycycline, and nitrofurantoin and fosfomycin are probably not good options here because these are bloodstream infections, and these drugs generally tend to have poorer blood levels and therefore not very good options. So as of right now, the question comes up is, can we use piperacillin tazobactam for ESBL bacteremia? Well, if the patient is sick, probably not the best option. Patient is not very sick and the patient is not a high-risk patient, you can consider it, I guess. But for sick patients in the ICU and unstable patients and patients who are high risk, no, you'd probably go with a carbapenem. However, if you've already started that and the patient is improving, then it's okay to continue this. But it's important to understand that BLBLIs have been de-emphasized in the current setting when it comes to initial empiric therapy for ESBL-based bacteria, which is what is common in most gram-negatives across India. So the other situation that I'm going to talk about is a patient who has chronic lymphedema. As you can see, this patient has a tender red leg swelling with fever and dry gus. Patient is tachycardic, blood pressure slightly on the lower side. As you can see, it's a nice red, swollen, and it's very, very shiny leg. So the question is, what do you want to use? Cefprozil, sulbactam, meropenem, vancomycin, amoxiclav, all choices that are often used. And you're free to use how many ever drugs you want. There are people who might use the quinolone. There are so many other options. The question is, what is the microbiology of it? That is important to know. For urinary tract and the infection in the community, we know the top two would be E. coli and possibly things like Klebsiella. You're not going to see Enterococcus is a major player there. You're not going to see so much of Staph aureus. So covering gram-negatives would be adequate. But here it's the reverse. It's primarily gram-positives. So remember that the most common organisms here would be Staphylococcus and Streptococcus. So this patient was started on vancomycin and of course a gram-negative agent because the patient was in ICU and obviously we were concerned. And the blood culture grows Staph aureus, which is methicillin-susceptible Staph aureus. So what should we do? Should we continue vancomycin? Should we continue vancomycin and repeat a culture? Should we switch to cefazolin or switch to cefazolin and repeat a culture? Now this is important to know. If you have staph bacteremia, you have to repeat a culture because the duration of staph bacteremia is important. Staph has very high mortality associated with this, and the duration of staph bacteremia is important because if you don't pick it up, you can miss seeding in other parts of the body like an osteomyelitis or even an endocarditis, and that can really increase your mortality. So repeating blood cultures in the setting of staph bacteremia is very, very critical. The other point is if you have methicillin susceptible Staph aureus, mortality is lower if you use cefazolin or fluoxacillin. It is important to remember that they are cidal drugs. Here it makes a difference. Vanco and daptomycin are not the right drugs for this. If you have MSSA, you should change to either cefazolin or fluoxacillin or flucloxacillin or something like that. They are much, much better and they have better survival. Vancomycin has poorer survival when it comes to MSSA. Of course, if you have MRSA, you may want to use vancomycin, daptomycin, teicoplanin, and one of those drugs. So again, remember that cellulitis, most of it is Staphylococcus and Streptococcus. And for Streptococcus, all beta-lactams are effective. Vanco would work, Clinda would work, a lot of drugs would work, but there's nothing with nothing like good old penicillin. And in staph, MSSA, clox and cefazolin are superior. You go for that and downsize to an oral agent as well. With MRSA, you want to use Vanco and Dapto, and then you can downsize to oral cotrimoxazole or other drugs like that, or even clindamycin if susceptibility is okay. What about BLBLIs and carbapenems? Routinely, no. There are some situations where gram-negatives become an optional situation. For example, diabetic foot infection or trauma-related. Somebody has had a penetrating injury or an operative wound. Those kind of situations, yes, definitely gram-negatives also become important. But for community-acquired skin and soft tissue infections of the extremities, definitely it's your gram-positives which are the major concern. So remember that for many of us, this can be a little bit of a shock because this is not what happens in regular practice. A lot of people forget to have very good gram-positive cover and they focus more on gram-negative cover. Remember, gram-negative cover is more for your urinary tract infection and intra-abdominal infection. For skin and soft tissue, it's primarily gram-positive. This is another situation which is going to be fairly different. Another skin and soft tissue infection in a different setting. This is a real life situation where we had this 53-year-old gentleman who underwent a living donor liver transplantation. He received the liver transplant 5 weeks ago and he was doing well. He was out in the guest house, coming for follow-up clinic and all that. And then he had a lesion on the gluteus, on his butt last week, which resolved with augmentin, and then has this new lesion on the leg. He seems afebrile and comfortable. So what should you do? Should you just give him, which antibiotic would you like to give him because he wants to go back home? The answer is no, you don't let him go home because this is a profoundly immunosuppressed patient. What ended up happening was they quickly took a photograph and sent me this. And then fortunately for us, we immediately took a biopsy of this, and it turned out to be mucormycosis, cutaneous mucormycosis, because he had scratched himself and inoculated fungus, and it already started going in. Fortunately, because we picked it up fairly early, we were able to excise it, give him antifungals, and he did very, very well. So remember that your microbiology is also dependent on the host. So the rules are different for different hosts. I'm not talking about a person who's a well-controlled diabetic. I'm talking about somebody who's had recent organ transplant. I'm talking about patients with febrile neutropenia. I'm talking about patients who have advanced HIV and are profoundly immunosuppressed. Those kind of situations, you have to be careful because the microbiology can change, and therefore your choice of drugs has to reflect that. And it can't be just that you give lots of antibiotics. Also keep in mind that once in a while you see unusual things like fungal infections, but that does not mean that we should cover for fungus and give amphotericin to everybody who comes in with a skin and soft tissue infection. The next one is a 27-year-old gentleman who presents with loose stools. This is a fairly common problem because GI-related issues are fairly common. Dr. Ram Gopal was also discussing about some of that. He's had 8 semi-solid, non-bloody stools today, and he's able to take orally, and he's making urine. He is at home, and he seems fairly comfortable. He has some fever and some vague abdominal pain. The question is, what test should you order? What medicines do you give? The point is that this is a young, healthy person with low risk. And the most common syndrome that you see is a viral gastroenteritis. A lot of diarrhea in the community is actually viral and really don't need antibiotics. You start worrying about bacterial infections if there is bloody stool, if there is crampy pain and abdominal pain when passing stools, if there's a lot of mucus in the stools, and if there's fever going beyond 48 hours, or this high-grade fever with rigors and things like that. Outside of that, in a healthy person, I'm not talking about a profoundly immunosuppressed person, in a healthy person, you don't need to do a ton of investigations and start giving them a ton of medicines. And in fact, antibiotics are mostly unnecessary. And here it's syndromic management. In my practice, this patient would have got a little bit of loperamide or some anti-secretory agents and good hydration and watch on their symptoms. If they're doing well, I do nothing more. I may not even ask for any test because it doesn't matter. If this person is otherwise a healthy guy, just wait it out. But again, it's important to make sure you follow through on this and make sure that the patient does well. Giving them antibiotics is just to cover our own discomfort with not knowing what to do rather than actually doing the patient any benefit. So when it comes to choosing antibiotic and choosing the right one, the first question is always, what is the diagnosis? If we don't have a diagnosis, the chance of choosing the right antibiotic is fairly remote. It's okay to make the wrong diagnosis, but it's important to make a diagnosis. It's not that we will have all the information at time point 1 when we see the patient. It's okay to go ahead and change it based on new data that's available. So if a patient comes in with high-grade fevers and chills and rigors and is altered sensorium, you don't know if it's hepatic encephalopathy or whether it's cerebral malaria. Only a test will tell you that. Unfortunately, till the test comes back, you cannot be sure one way or another. But having said that, it's okay to say, I think it could be hepatic encephalopathy, or I have to rule out cerebral malaria. It's okay to say that. It could be leptospira. It could be any number of things. So it's okay to be uncertain at time 1, but it's at least important to put down saying these are the possibilities I'm thinking of, and this is how I'm covering this patient while I'm waiting for more tests. Second is, who is the host? Obviously, a young, healthy host in good shape is not the same as somebody who's older with, say, an organ transplant or cancer chemotherapy, because they are very, very different. The third is, what is your microbiology? So in a hospital-based setting, you need to know your antibiogram to decide what antibiotics to use. In the community, again, you need to know what happens at what time. So at this point, let's say if somebody comes in with a body ache, fever, and runny nose and sneezing, like all of us are enjoying right now at home, we know for certain this is going to be influenza because COVID is fairly less likely at this point of time. And there's a lot more influenza running around. But of course, you want to test for it. Is there a risk for drug resistance? So what are the risk factors? Is this a patient who's a frequent flyer in a hospital? Has he been recently exposed to broad spectrum antimicrobials? All those things. You need to look at all of that. Also remember that in our country, our baseline self is an ESBL producer for even people who come into the community. What is your hospital antibiogram? It's nice to look at national guidelines, but India is a subcontinent all by itself. We have more people in India than they do in the United States and Canada put together and multiplied by 2 also. So the data that we get is not necessarily the same for everybody. So keep an eye on your own regional antibiogram or local antibiogram to try and figure out what works and what doesn't. It's good to have data coming from your own neck of the woods. I think that is definitely useful. And again, look at what is the best agent based on penetration and toxicity. Toxicity should be the last concern. You should look at the benefit first, because if the patient is dead, toxicity is of no concern. More people die of antibiotic not being appropriate rather than toxicity per se. So it's important to remember that we need to hit the bacteria hard and appropriately and not worry about toxicity at time point 0. So again, like I said, penetration, certain drugs like tigecycline is no good for the lung. For intra-abdominal infection, it's a great choice. For urinary tract, it's a pathetic choice. So again, look at all of that. And this is one issue which often makes where mistakes happen, the correct dose. Very often I've seen people indulge in homeopathy, hoping that because of lower doses, toxicity will be less. Here's the problem. You may not get toxicity, but you may not get any benefit also. Antibiotics only work if they hit a certain level and they start killing the bacteria. If you don't hit those levels, the bacteria are not going to die and you're only killing the patient. You're allowing the bacteria to kill the patient. And I believe the technical word for that is euthanasia. So we should not do that. So let's make sure that we give the right dose and not worry too much about toxicity. Another common area where mistakes happen is in acute renal dysfunction. Most of the renal dosing is meant for patients with stable chronic renal failure. A lot of our patients in ICU have acute renal dysfunction. So I see often patients who have a renal injury where the creat is elevated, but they're pouring lots of urine, which basically means their renal function is actually not so bad. So dosing it according to the creatinine often leads to inadequate doses, and we need to be a little more generous, because if we don't give them adequate doses, obviously you're not going to get the benefit of this. The next issue is about making sure we have blood cultures or appropriate cultures for that matter. When you have a patient coming into the hospital and who's sick, make sure that you clean the skin properly. Instruct your staff to clean the skin with chlorhexidine, not povidone, and get good samples. The problem is that if you don't follow this, you're going to have a lot of skin contaminants growing, and that's going to reduce your pickup of bacteria, and that's not good. You want to have a very low skin contaminant rate. You need to have good blood cultures. You want to get at least 2 sets of cultures. Studies have shown that it improves the pickup rate from 65% to 91% from 1 to 2. You need to have 1 aerobic and 1 anaerobic, 40 ml of blood. See, we have 5 liters of blood, that is 5,000 ml. Nobody is going to die of 40 ml being lost. So I don't think we should worry about that. Please make sure you take enough blood volume. Obviously, pediatrics is different, but make sure enough volume is inoculated. With every ml of blood which is not inoculated, there is a drop-off in blood culture pickup rate. You don't need arterial punctures to do that. Even good venipunctures from different sites are good enough. 2 separate venipunctures, 20 ml from each venipuncture, inoculated in 4 different bottles, 10 ml in each, is the best way to go. And so, some points to remember. The best thing, when people ask me what to do with the swab, I ask them if there's a dustbin nearby and immediately put it inside that. I hate swabs. They don't tell us anything. If there is a collection of pus, the best thing to do is put a sterile syringe and needle into it, aspirate it, and send the whole thing off to microbiology, because they can do so many more things with that rather than just see some bacteria and you're wondering, what is this? So do not send pus samples, do not send swab samples, send pus, send tissue, send good samples. And again, before you start culturing everything, look at the gram stain, because if the gram stain and culture don't correlate, you got a problem. It doesn't mean much. So things like sputum and urine should always have a gram stain before the culture, and obviously using serological tests in selected patients. Of course, there are barriers in all of this because there is always diagnostic uncertainty, at least in the beginning. And negative culture reports are not uncommon, mainly because a proper sample has not been obtained, or you need lots more sample. And of course, the clinician's confidence in both the diagnosis and also in the lab. So the general principles, to reiterate this, always make a diagnosis. Yeah, I'm almost done. Make a diagnosis, make sure there is, it is essential for appropriate therapy, limit appropriate therapy based on what you think it is. And of course, interpret your reports very, very carefully. Do not treat colonizers or contamination. Understand what is true infection. Use PK/PD parameters. So if you're using aminoglycoside, the recommendation is once daily therapy. So if you're using something like amikacin, it will be 15 mg per kg, once daily, 100 ml normal saline over 1 hour. It improves success and reduces toxicity. Do not split aminoglycosides except for enterococcal endocarditis. That is different. Everywhere else, it is once daily. There is no role for splitting it. There are some situations where you can go for continuous or extended infusion like beta-lactams, but understand that not all beta-lactams can be given over long periods. For example, meropenem beyond 3 hours, it's unstable. You should not be giving over 3 hours, more than 3 hours. There are some times where we use combination like colistin with beta-lactams and things like that, but understand where it can be and what is the value of that. And most importantly, look at de-escalation and discontinuation. Reducing medicines and stopping medicines is probably the best thing you can do for your patient, because there is good data to suggest that it actually improves overall outcomes. Also remember, there are things you do not treat. Do not blindly send ET aspirate cultures because it will grow something. It is not a sterile loop. It doesn't matter how sterile you think it is not. It will grow bacteria. So unless a patient has a problem, do not blindly get cultures. If there is a VAP, make a clinical diagnosis of VAP and use this to decide what antibiotic is. The microbiologist should never tell you that it is a VAP. It is your call. Microbiologists only tell you this is the bacteria. The bacteria doesn't decide whether it's an infection or not. You do. So again, CVC, central venous catheter, a lot of people still take the central venous catheter and send the tip for culture. The best thing you can do, the tip is put into the same garbage bag as the sterile, as the swab, because the current recommendation do not recommend that. If you're worried about line-related infection, take a blood culture and take out the line and put another line in some other place. And again, once you have Foley's in, no urine is going to remain sterile. It will grow some bacteria or the other. It doesn't mean anything. Unless they have clinically symptomatic urinary tract infection, you do not treat cultures. Finally, sepsis mimics. There are some things which look like infection. They are not, like pancreatitis, heat stroke, even heart attack, malaria, hypersensitivity reactions. A lot of these things can look like, or rheumatological conditions, MIS after COVID. A lot of things look like sepsis, but they are not. They're actually other causes, either mechanical or immune-based. And it's important to recognize those and treat them appropriately. They really don't need anti-infectives. Yes, there are lots of guidelines on how to de-escalate and reduce medications. And the best advice is probably what we call start smart, and then focus. Make sure you have the right drug, right dose, right time, and right duration every time. And at about 48 to 72 hours, review the data and see, can you make this easier on the patient? Can you make this easier on yourself? So look at all of that and then decide what you need to do. So again, to conclude, there are no magic bullets. It's vain to speak of cures or think of remedies until such time as we have considered of the causes. Cures must be imperfect, lame, and to no purpose, wherein the causes have not first been searched. So if you can't find the reason, the chance of success is pathetic. So again, be very careful. And in antimicrobials, at least, very often less is more. So we need to understand our own limitations and make sure that we stay within the dotted lines. Sometimes experimenting can be very, very hazardous. And with that, I will stop. Thank you.
Thank you, Subrat. Can you hear me? Yeah. Can you hear me?
Yeah, very much.
You may not be able to see me, but you can hear me. Anyway, thank you. Thank you for delivering this talk. Nobody else could have done it better. If you didn't do it, I was supposed to do it. But thank you so much for doing it. But I have one question to you.
Yes, sir.
Yes, I agree with all of your principles. What do you do if the microbiologists do not grow the organism for a community-acquired and for a hospital-acquired infection?
Excellent question. Excellent question.
Stop.
What would be your drug of choice in today's scenario? Growing the antimicrobial resistance problem in the community for an organism that can cause in a normal host an infection. In your hospital, it's different because you treat a different case mix of patients. But leave aside the transplant patients and the immunocompromised, and otherwise healthy person comes to you. What is your drug of choice in the hospital for a sepsis, and what is the drug of choice from the community?
Excellent question. Thank you for asking that. And let me first acknowledge that most of these principles are very clear in my mind because I've been trained by the master who's now asking me a question. So I don't know if I can do as much justice as he can, but I will certainly try. So let me put it like this. I have always been taught that if you put down your diagnosis and you treat for your diagnosis, and if your diagnosis is based on a clinical think through, the chance of error is actually very, very low. Let me explain it like this. There are a lot of patients who come in from the community with fever. Typhoid is both over and underdiagnosed. In my experience, I've seen people missing typhoid because they've thought of other things when it is actually salmonella. And I've seen people treat for typhoid when it's actually something else. So the problem is that we need to understand the disease process and to know when to suspect typhoid. Somebody who has fever for a week now and now has a new onset dry cough and an eosinopenia, the chance of it being salmonella is incredibly high. Vidal is a poor test and I don't believe in it. I have not ordered for it in about 18 years or so. So in those kind of situations, even the blood culture doesn't grow salmonella, it's not going to deter me from using, say, azithromycin or cotrimoxazole. I'm not going to use anything more than that unless there is something else happening. So you have to back your clinical judgment whenever we have clinical situations where we can't really nail down the diagnosis. Keep in mind that the number one reason why we don't nail down diagnosis is probably because we haven't done enough to nail it down in terms of sending appropriate samples for testing. But even with appropriate samples being sent for testing, sometimes the pickup is poor because the patient may have already taken some antimicrobials, or it is a difficult to identify pathogen, or the infection may be intermittent and therefore you can miss one sample. So again, I think it is okay to miss the diagnosis based on microbiology, but that's where your clinical acumen comes in. If the clinical signs and symptoms are very, very typical of salmonella, I would treat for salmonella and not worry about the culture being negative. Yes, I would look for clues to suggest an alternative diagnosis, but that's not going to deter me from treating it for that way. Even in a hospital, again, I would start by looking at what my clinical diagnosis is. Is it a urinary focus of sepsis? Is it an intra-abdominal focus of sepsis? Is it from the chest? Is it from the CNS? Is it from the skin and soft tissue? Keep in mind that, for example, if it is cellulitis, if a person comes in with sepsis and the skin and soft tissue changes may not be evident on day 1. It may start coming out on day 2 or day 3. So in those kind of settings, it's important to keep re-examining the patient again and again on a daily basis to see if more clues have come. And sometimes it comes through on the 2nd or 3rd day, and that can help you shore up your diagnosis. And this is where I believe your diagnostic acumen is very, very important. Dr. Dilipathy has taught me that 85% of the clinical diagnosis is made from history, another 5% from examination, and only the rest of it comes from testing. So therefore, it is important to back our clinical skills and go back to the patient again and again and look for it again and again, and then go about it systematically. One valuable tool which I have realized over the years to be excellent is actually a problem sheet. Dr. Dilipathy taught me this. I wish he could show this to everybody as to how to do it. It's actually so simple and so brilliant. There's no two ways about it. Sometimes if you list down all the clinical problems that the patient has, put it as syndromes, and then try and come out with the most logical answer and use Occam's razor, meaning in terms of use the simplest explanation to explain all the answers, 99% of the time you will find the answer without having to do complex testing and resorting to very, very expensive things to do. So I think in most healthy patients, it's a step-by-step evaluation and doing it again and again that helps. While testing is definitely a boon, we have to accept that testing is not 100% perfect. There is nothing in life which is 100% perfect, including testing. And therefore, we should accept that our clinical judgment has to be paramount, and it is something we need to back on a daily basis.
Thank you. Thank you, Dr. Subra, and thank you for your participation. And I would suggest that you go back to taking care of your son, and you should be the best specialist for your son because you are the physician for a son who has a fever. Okay. All the very best, and thank you so much for your time. And thank you.
Two last comments to make. From this program, I think from the morning I've been hearing about this viral list. At least there are almost 100 people sitting here. Please, I think I was earlier saying that I would like to become Prime Minister of this country for one day, at least for 1 hour, to ban this viral list. This is something which probably is very important in our country, probably over-diagnosing typhoid. That's one comment. The second comment I would like to make was very important thing which Swaminathan told. One cephalosporin resistant, one cephalosporin, please do not consider other cephalosporin. I mean, one beta-lactam resistant, do not consider. You can consider BLIs, but not beta-lactams. But I wanted to ask the same question our doctor, beloved Dr. Idsa have asked. The question about the antibiotic choice, but I would like to ask a little additional to that. People have started using, I mean, for anaerobic coverage, people use additional drugs like metronidazole or clindamycin. Once they have started meropenem, because most of the sepsis infections are there, the aspiration pneumonias or the respiratory or the pyelonephritis infections, whatever. What is your take on this? Adding in clindamycin or metronidazole in case of a pneumonia or in pyelonephritis? And the second question is, how long would you wait to escalate the antibiotic before starting presumptive treatment, before the reports are available, but still the patient is not improved?
Sir, I'm not.
Sorry. So the first question is about anaerobic cover. Let's first accept that all BLBLIs, beta-lactam inhibitors like tazobactam, sulbactam, and to a good extent clavulanate have very good anaerobic cover, as also the carbapenems like imipenem and meropenem. The newer BLBLIs, ceftazidime-avibactam does not have anaerobic cover, but all the older BLBLIs have excellent anaerobic cover. So if you're using something like cefuroxime, sulbactam, piperacillin, tazobactam, imipenem or meropenem, you don't need metronidazole. What will metronidazole give you extra that these can't? Clostridium difficile cover, but you're not treating for Clostridium difficile. It can treat Entamoeba histolytica, but you're not treating Entamoeba histolytica. So outside of that, it will cover everything else. So there is really no reason to add metronidazole for additional cover. And I think people underestimate the kind of side effects you have with metronidazole. I have a terrible bitter taste in my mouth, and I hate having to take any of the imidazoles for that matter, whether it's tinidazole or metronidazole or whatever it is. I hate them. So I don't know how many people have taken it in real life. A lot of people have side effects with this. And this is not to forget about the disulfiram-like reaction in case they do take alcohol. So there are quite a few problems with using metronidazole. So let's not underestimate how, and there's also some weird neurological complications that can happen with it. So metronidazole is not an innocent drug that people make it out to be, and you don't need it if you're using a beta-lactamase inhibitor or a carbapenem. It will cover everything. The second question is, when do we escalate therapy? The only time where you need to be really uncomfortable is in a neutropenic patient. Outside of that, if a person has persisting fever or symptoms, the way I teach my PGs is 3 pillars. The first pillar is your diagnosis correct? If your diagnosis is wrong, then there is a problem. Maybe you need to go back. Maybe there's some clue you missed, and something else has come up that will explain why the patient still has fever. The second pillar is the treatment correct? Is the agent correct? Is the dosing correct? Is the route correct? Sometimes we are underdosing. Maybe we are not using the right agent. Maybe the penetration is poor. Maybe there is drug interactions, any number of things. And finally, is there a complication? Because sometimes, let's say you're treating a pyelonephritis. You may be using a carbapenem, which is very good, but the patient may form a renal abscess. And that's part of what happens with pyelonephritis. So if the patient develops a renal abscess, the person can have persisting fever. So that's why if you look at pyelonephritis treatment, if you have persisting fever for more than 3 days, then most people would say, okay, it's time to get an ultrasound to make sure there's no obstruction or there's no pyonephrosis or something like that. So I would always look at it as 3 pillars. Is my diagnosis right? Is my treatment correct? And finally, is there a complication?